Welcome to the Conversations on a Collective Approach to Children's Mental Health. This is a virtual forum series that is hosted by the American Academy of Child and Adolescent Psychiatry. My name is Desiree DeBella. I am an ACAP Emerging Leaders Fellow. I'm a pediatrician and a child and adolescent psychiatrist, and I'll be leading today's conversation. So this series is a part of ACAP's presidential theme, which focuses on strengthening collaborative multi-sector approaches to supporting the mental health and emotional well-being of children and adolescents. Today's session is especially focused on the intersection of child psychiatry and the education system. So we are honored to be joined by Dr. Carol Vidal. She's an ACAP member who works as a child psychiatrist in a school-based mental health program, and Dr. Nancy Lever, who works as a clinical psychologist whose career centers on high quality and sustainable school health efforts. So thank you both for being here today and sharing your expertise. Before we get started, I just wanted to let all the members who are joining us today, if you are having technological or logistical questions, please enter them into the chat and an ACAP staff member will assist you. If you have any questions for our panelists today, please enter those into the Q&A box. And then please note, due to time constraints, it's unlikely that we are able to answer all of the questions today, but we'll do our best to get through as many as possible. So yes, and these will be recorded. So we will go ahead and get started. So our first question, just to begin, could you all, Dr. Vidal and Dr. Lever, please share a brief overview of your background and your current role, and then just speak to how your work contributes to the broader system of care supporting children's mental health and emotional well-being?
I'm happy to start. So I'm a child and adolescent psychiatrist, and I have a background in public health. And my role is assistant professor in psychiatry and behavioral sciences at Johns Hopkins. And my job right now is it has three parts. One, which is the biggest part at the moment, is I'm doing research through a K-12 award from ACAP and NIDA, and I research substance use and depression and suicide-related behaviors in adolescents. And then I have funding from the Maryland Health Department to conduct a program which consists on suicide prevention in schools in Baltimore City. And I can talk about that later a little bit more. And then my clinical work is actually as a school psychiatrist in an expanded school-based mental health program that runs through Hopkins, but there's different organizations, including the University of Maryland, that serve different parts of the city. And the way my work contributes to the broader system, I think because of I go to the schools to see the patients, I think it contributes by helping patients get evidence-based treatment in the places where they spend most of their time. I think, yeah.
Okay. Hi, everyone. I'm Nancy Lever. I am the Executive Director of School Mental Health for the National Center for School Mental Health and an Associate Professor in the Department of Psychiatry at the University of Maryland School of Medicine. I'm a clinical psychologist, and I work across research, training, policy, and practice to advance school mental health best practices at the local, state, and national levels. I work across education, mental health, and health systems, and with other child-serving systems, depending on youth needs. Ultimately, all the work that I do is connected to making sure that all youth have access to mental health services and supports in schools across a multi-tiered system of support. And I just want to echo Dr. Vidal's comment that, you know, one of the best things about school mental health is that we're able to provide services and supports where students are. So they're in schools, and we know that often they struggle with being able to get to traditional places for mental health and health care. And by going directly to them, you can help reduce some barriers to care.
Thank you both. And I imagine with you all, working both in the school sector, there's probably a lot of overlap with your work. I guess starting with you, Dr. Lever, how do you feel like your work fosters social connection and the emotional support and community engagement for families and children? And could you share an example of it?
Sure. All the work that we do really crosses family, school, community partnerships. And I do want to emphasize that, as a community partner working in schools, it's not either or. Like when there's school employed staff, when there's community partners, it shouldn't be one or the other. It should be both and. And our goal is to work with school employed mental health staff, and to figure out how do we all work together to provide, as I talked before about a multi-tiered system of support. And we want to make sure we have a system that you want to make sure that you don't have to reach the highest levels of need in order to get support. So being able to provide mental health promotion and prevention services and support. So basically going into classrooms, providing assemblies, reaching out at the grade level, and we can make sure that all students are exposed to social emotional awareness and skills along with other students. And we level the playing field by basically making sure, not assuming that everyone is coming to school with all of these skills. So we're able to teach these skills to children and to their families, through outreach and education, and it just becomes part of the school environment. You asked for an example of where we've seen a difference with social emotional learning. And one of the exciting partnerships that we've seen be very successful is one of my colleagues has been able to work with the faith community, and they were trained in a Strengthening Families program, and then they were able to work with our clinician to encourage families and youth to take part in these groups that were happening after school and on weekends, but they were led by the faith community. So it really is an example of, teaching evidence-based programs and not just saving them only for the mental health providers, but really bringing them directly to the communities to have a greater chance of reaching youth and families.
And I would also echo what Dr. Lieber was saying. I have to say, in my program, the expanded school-based program that she's very familiar with, also, we have the therapists we have a therapist in each one of the schools, and then the psychiatrist has a team and visits several schools to provide medication management or diagnostic clarification. And the job of the therapists is not only to provide clinical services individually, but they also do group therapy. They go to IEP meetings, they communicate with teachers and school counselors that are employed by the school system. So I think there's a big systems level type of connection. But I also think that as a clinician, by virtue of our profession, we have to connect with patients in order to do our job, because behavior change doesn't happen, or emotional support doesn't happen without some sort of connection. And that happens especially with younger kids. We have to spend a lot more time engaging with them. And I feel like when you go to the school, that sort of like takes care of a lot of those steps, because they see you coming into the school and they tend to feel like, at least that's my perception, that you may be more open to their experiences, or that at least you're part of the community in a way. So yeah, as a having to just travel and go to seek services. And also to say about what Nancy was saying about the levels of care, I think it's important to think about psychiatrists. We have all these tools, And obviously, there's so much need for inpatient services and residential treatment programs and high intensity level type of treatments and specialized clinics where maybe you do have to travel to that clinic. But there's also a lot of room to provide evidence-based services to kids and adults as well that may not need that high level of intensity. And I think school-based is really great for that because you can reach people that maybe are starting to get sick, but they're not so sick, or or maybe they just need some support. And in terms of an example, I think one of the things that I love more about the school-based program is that the hierarchies are softened a little between the doctor and the patient. So because you go to their space, right? So I have one patient, for example, this is one of the last examples, but he actually I've been seeing him since he was a freshman in school, and then now he's going to become a senior. And I've only seen him in the school. I've never seen him in the hospital or in an outpatient clinic. And then now he got a job because he's doing better, and he got a job in the grocery store where I go. So I also see him there, and it just feels like, he's never seen me in a healthcare setting, but I'm providing healthcare. So it feels like, part of it is this Baltimore is Baltimore, and everyone navigates the same spaces. But I just feel like it really helps with trust. And he doesn't call me doctor; he calls me Vidal. But it's just another type of relationship than the one I've had other times when I was maybe attending in the inpatient unit or so. So yeah, and then also at the same time, I go to schools where my kids have friends, and they see me there. So it's really very much a community, and it just feels like you're just one other person with a slightly different role, but you're just, part of their community.
If I can just add to Dr. Vidal, like school mental health can really help reduce stigma. It's less intimidating to see, your health or mental health provider in the school, and they just become part of the community. They may still go to like school dances. They may, participate in after school activities, and it just can be less frightening than having to go somewhere and go into that separate office. And we do have separate offices, but it just feels less intimidating when you're in a school and you're kind of meeting them where they are.
You took the words out of my mouth. I was going to say you're both emphasizing this idea of community and being, working as a bridge to that community. And, Dr. Lieber, you spoke about even the inclusion of another sector, the faith sector, into the example that you gave, and how when you include all of those pieces, it's normalizing. Like you said, it reduces that stigma. Absolutely. So I would love to know, more about how do you ensure that the work you're doing in these schools, in these communities, is culturally responsive and inclusive? And then what insights from your work do you feel like can inform more equitable practices within child psychiatry and healthcare? And Dr. Vidal, do you want to go first?
Yeah, I'll go first. I just have to say about this topic that I think I try my best but I think that I have sort of like an advantage because I'm not from the United States. I came here as an adult, and after going through college and stuff. So I feel like because of my situation as an immigrant, I have to be very open to learning about other cultures. And to me, when I came here to the United States, Black culture or like Native American culture, white culture were all different for me. So I think I've like sort of exercised that muscle of trying to just figure out how people think and how they behave differently from the way I grew up. And so I have to check my biases a lot. But through this process, I feel like I've learned a lot, and I've changed a lot from when I came here until now. And I think one of the great things about these countries, there's so many different subcultures, and it's really kind of exciting. But you do have to sort of like stay on your, stay alert about like differences or how you might, understand behaviors or the way people think differently depending on their background.
And I would say that, our clinical teams are always looking to learn how to best support, each individual student and to figure out and understand the culture and history of different groups that represent the students and families that we serve. And you can never ask too many questions. If, sometimes the best way is just asking those questions. Help me understand what's important to your family. Tell me about your history. Tell me about, what's important to you. What are some of the holidays you celebrate? I think just learning and asking those questions can be pretty important. We also have a consultant who we work with to make sure that, we're continually growing. If you ever think that you've achieved cultural responsiveness, then there's a challenge there. It's something I think that we always strive towards, and it's always evolving and changing. So I do think, having meetings, trainings, discussion is important, but also getting that information from youth, parents, caregivers, educators, school leadership. Like, you can have feedback surveys, you can have groups, you can ask them, is this working? What would make it better? Would you recommend it to a friend? Why or why not? And taking that feedback and learning from it is absolutely critical. We also try to make sure that we have an advisory board that includes youth, families, school staff, community perspectives, but it has to mirror the student body being served. So it should look like our students. How do we make sure we're providing what they need?
Yeah, and I wanted to add that I think this is like an ongoing, needs a lot of work for a long time. For example, one of the program that we're doing for suicide prevention is the two staff members that have been delivering it for the most part, they're noticing that the feedback from the middle schools, for example, is that maybe they already know the stuff that we're teaching them, or that maybe they've experienced things that videos are not showing, because it's a series of videos and discussion. So I think that in terms of like how even the new generations are different from the way we grew up. So in terms of age, but also culture, you always need to be adapting the interventions that you do to the specific group that you're serving. And they're the best people to tell you if it resonates with them or not, right? It's not you telling them. So yeah.
And youth are very honest. If it's not helping, they will let you know. And families too. Like this, you're providing these services to students, but also to the families. And, they can help us figure out what's needed, and they know their child best and can definitely contribute to a better, more complete understanding of what would be most helpful to the child.
Yeah, that's definitely that they will tell you the truth is, man, that absolutely. Are there any other tools or indicators that help you all evaluate the effectiveness of your work? It sounds like you do a lot of feedback with the communities that you work with, both the children and the caregivers, making sure that you have these people in the background or that are working with you to constantly assess how well things are going, but any specific tools that you're utilizing?
We definitely encourage the use of our National Center's School Health Assessment and Performance Evaluation System, which comes out to the SHAPE system. And you can use that at the school, district, and state levels to evaluate the quality of services. And it's really at the same time that you're about assessing quality and where you can improve across 7 standardized performance domains. Just by having conversations with a team, you're kind of doing, an assessment as evaluation, as assessment as like quality improvement. Just the process of talking about it, brings people together, and you start to realize, well, here's what we can do to improve. And you can use the SHAPE system intentionally to do quality improvement. There's also measures on early childhood mental health, family engagement, cultural responsiveness, trauma-informed care, as well as organizational well-being. In addition to that, you can keep track of other measures. So you can do some level of measurement-based care and get a sense of using standardized measures, like, does the child have less depression? Do they have less anxiety? And, look at the start of treatment, look 3 months later and continue to evaluate and be willing to say, gosh, it's not improving. And if things aren't improving, maybe we need to do something a little different. It's also, if you're going to understand impact and you're working in a schools, part of our mission is to help to make sure that youth are being successful in school. So, I would say also looking at grades, attendance, expulsions, referrals to the office, just to get a sense, are we helping them to function better in their environment, which in this case would be the school building.
Yeah, I mean, I really have very little to add to what Nancy said because they're the experts on collecting systematic data and systemic level data. But I have to say that because our program is basically essentially taking the clinic to the school, we use the same type of tools that we would use in the outpatient clinic, like the PHQ-9 and the AGAT-7, and then we get to do repeated measures, and then we also have a quality of life scale that we do pretty frequently at each visit. We also check for substance use from visit to visit. So I think we use kind of the same tools that we would use in clinic. I think one of the things that doesn't always get reflected, except for when you write your note, is that there's like in general, like the kids do better, and isn't like soft things that, like what Nancy was saying, that we don't always collect necessarily in the clinic. Like they come to school more frequently, they decide to go to prom as opposed to trying to avoid going to prom, or they get a job, or like they engage in like the work program in the summer, things like that. And then in terms of the state grant that we have, it's the same thing. So we count the people that we serve. We count the people that we provide services to, or that need extra help, or that we do evidence-based practices for like short interventions for suicide. But I think there's other things that don't get always counted. For example, the fact that like maybe there's 3 kids that never had mental health treatment before, and then thanks to the program now they're seeing a therapist, and they wouldn't have been identified as at high risk for suicide if it wasn't for the program. Or that maybe because of the 2 programs that I have, so the clinical program and the state grant, now there's a lot of collaboration in the places where we've delivered the program for the state grant, which is mostly educational and referral, between those people and the expanded school-based mental health staff. So there's more cooperation, and I think those are sometimes things that are harder to measure, and qualitative data is great, like Nancy was saying.
Yeah, those subjective pieces where they come in and they're smiling and they're like, I went on the field trip, or I went and I talked to that friend group that I was really nervous about, going up to last week. Yes, definitely. Both the qualitative and the quantitative data for sure. Now,
I think
If I can,
oh
sorry.
yes, Dr. Lever and Dr. Vidal.
Yeah, go ahead.
Dr. Vidal, you go first.
Oh, I was just going to say that I think from my experience, when I was serving the same population from the outpatient clinic during my fellowship, I would get 3 visits and that was it, because then they couldn't make it back. But now I get to see them over time for 4 years sometimes, because I'm doing just high school right now. And during that time, I have plenty of PHQ-9s throughout all that time, and also a lot of like reference of how they were doing at the beginning of treatment and later. So.
And I just wanted to reiterate your comment about who's being seen. And I think, this is a classic there's several misunderstandings about school mental health. Sometimes I think people think that the youth that we see in schools have fewer problems, not as serious concerns as youth who may be seen in an outpatient mental health setting. And I would say often it's the opposite that's true, because if someone is going to make it to the outpatient setting, they have to have like a family member or someone that's gotten them there. And many of the youth that we're serving are youth who otherwise may not have received any services, even though they may have some challenges that are pretty apparent and even documented along the way, but no one has ever done a formal referral or exposed them to any mental health supports. I also wanted to mention, as we're talking about, what are some of the measures that we should be considering? Often our measures in mental health are kind of all based on symptomatology. There's like, I don't want to say it's a negative, but it's all like, what's wrong? So sometimes it's helpful to also be thinking what's right, what are some of the strength-based measures, what are some of the skills that they may have, and some of those are social emotional competencies that youth may have that can help them when they experience mental health concerns. So just want to put in a plug that as you're thinking about assessment, think beyond just symptomatology and look to that broader functioning of youth.
Thank you so much for pulling out those important pieces, both of you. Now, considering some recent changes under, politically, socially, what are some of the most pressing challenges that you all face in promoting children's mental health and development, and have some of the changes that have happened politically and socially influenced your work, and how are you adapting? And yeah, go ahead, Dr. Lieber. I was just going to call on you.
Okay. Um, I think that, post-pandemic, we realized that, there were increases in anxiety, depression, trauma, and numbers, if anything, were going up. Like, so the need for mental health services and supports, and they referred to it around that time, the Surgeon General talked about it being a children's mental health crisis. So you're coming in and we're already at a high level of need for child and adolescent services and supports. And then at the same time, in our current system, we're talking about funding cuts and reductions in Medicaid and other funding grants and opportunities. And yet that doesn't change the mental health needs that we have. So figuring out like how can these programs, how can school employed staff continue to meet the capacity needs of meeting the needs of the mental health needs of all students? How do you do that as some of the funding is, being cut, and it's getting more challenging to continue the pipeline of mental health supports and individuals going into the field? When I think about, where we are now, it's just some things to consider that in our political climate, like we know that mental health is equal opportunity. It crosses over all demographics, all socioeconomic status, all political parties. So it really needs to be a bipartisan issue. And it's something we need to agree that mental health, well-being of students, regardless of affiliation, is a health priority that needs to be addressed. One other consideration as we're thinking about programming in schools, when we have our education system view academics separately from mental health and not thinking of the needs of the whole child, if we think of, anything to do with mental health is kind of like an add-on and not part of the same system, it becomes a burden. And we don't want that system where, we need to think of that mental health and education integration and bringing that all together versus kind of separating them out. But what we do know is when those mental health needs can be addressed. And this, I think, is important when you integrate that. Ultimately, there are studies, there are findings that show that there's more teaching time. Like, people are so worried sometimes that this is going to take away from teaching. But if you address those basic needs, children are better able to learn.
I personally think that there are challenges at all levels of the socioeconomic status. classification, right? But I think that for me, the biggest concern right now is the income inequality, which was already a problem for the United States as the country, the developed country with most income inequality in the world. And now it just feels like with the new policies, it's just going to get worse. Unfortunately, for the patients that I've been working with, um, things got better for a little while, but it's consistently being not great. So I feel like the work that I'm doing, I just feel more motivated to continue doing the work that I'm doing. But I do think that, like Dr. Lieber was saying, when you talk about cutting, for example, Medicaid, that means that maybe programs like our program that are basically serving a population that's more vulnerable and that doesn't have the means to go through the private route or pay for services themselves. That really puts a lot of people in danger of having worse mental health. And because these programs could be in jeopardy. And then also, I mean, there's also real issues with access, for example, among Hispanic populations that were dependent on grants that now are being defunded. So there are real issues with access that are directly impacting mental health access. And then there's also the issues with if you cut public services at other levels, like for example, transportation or education, or even like environmental protection things, there's populations that are going to be more affected because they don't have the ability to be mobile in their housing or just to pay for private services. So I think that also indirectly affects mental health. So I am concerned about this. I think the most frustrating part of politics these days is the lack of continuity. It seems like people are more concerned about doing the opposite of the other party as opposed to just being concerned of progressing forward and trying to do what's best for the people that voted them or that they're serving. So yeah, I think that is kind of exhausting. And I think in terms of adapting, I'm just trying to do my best to do what I can with my job. I don't know what will happen if there's cuts in Medicaid, because our program is fully based on Medicaid. So all of our patients are Medicaid patients.
Yes. And I certainly have patients of my own that in terms of therapy services, if they did not have school-based services, they just would not have access to high quality therapy. You both mentioned so many pieces that point to supporting integration as this kind of pathway to make things more equitable, and all of those other pieces that you need to fund in order to provide patients and families with like high quality like healthcare, just period healthcare. So I want to know like what role do you all see as like for child psychiatry in terms of continued collaborative efforts with the education sector, both now and in the future? Thinking about that integration type piece. Dr. Lever?
When I think about child psychiatry, one of the things that we've been able to do that I think has made a big difference is as part of their child and adolescent fellowship, our child psychiatrists are going into the schools, and whether they continue in school mental health or not, they have a much better understanding of the school system, of the community, that there's a lot that they can gain that I think will help them in their future careers as a psychiatrist, no matter what the setting. I mean, I think if you're going to work with children and adolescents, you do need to understand schools and school systems. And if you're seeing a student outside in the community, you want to know what's going on in all components of their life. And, I'm sure many of us have worked with adolescents, and you ask the best open-ended question, and somehow they say yes. And yes can't be an answer or good, or, it just doesn't fit. So I think having that understanding of what's happening in schools, what's happening in the home, what's happening in the community, in your office, and all these other places is really important. And, I would love to see all school systems having access to psychiatry. I think our psychiatrists can, do a lot more than just, I think sometimes people think psychiatry, med management, but we have to go beyond that to like just diagnostic clarifications, awareness of resources and supports, and being part of IEPs, individual education programs, and other things, so that they're bringing a different lens, and compared to our counselors, social workers, psychologists, our psychiatrists are coming with a medical lens that a lot of the other groups do not have, and we want to make sure. I think it's important to bring that biopsychosocial perspective to the table, and to consider like how should that be integrated into everything from assessment to treatment.
Yeah, and I would say I'm the perfect example of what Dr. Lieber was talking about, because I was part of that. I did my fellowship at the University of Maryland and really didn't know anything about school-based mental health. And when I experienced it, I loved it. And then since I took an hiatus just because I wasn't needed in school-based, but now at Hopkins I'm doing pretty much the same work that I was doing there, and it was thanks to my experience doing training. So I got to see the west side of Baltimore and not the east side. But in that sense, I think that collaboration for psychiatrists, especially a child psychiatrist, is not it's not a choice. I think it's like a must. We have to do it because most of the kids need services. Most of the kids that need services don't get them. The kids with substance use problems hardly get any services. There's a huge gap there as well. And I think we have opportunities to work with pediatricians, with schools, and we definitely should do that, be able to consult and provide our expertise. And obviously we can't serve anyone, like all of the kids that need services directly, but there's so many people that we could train, like Dr. Lieber's program is doing. And it doesn't necessarily have to be highly educated people or people who have gone to college. It could be people with less training, or just people with the lived experience, which sometimes are the most powerful people to help with behavior change. And one example of that is the models that were the City of Baltimore is doing for community violence prevention. They're actually using people with lived experience who have been involved in the criminal system, and that maybe have been in jail, but then they've recovered, and then they're the ones that are able to mediate and prevent community violence, and they've been the most successful. So I think there's space for a lot of people, and I think we have the knowledge and the evidence-based interventions that we could be using, and it's a question of just organizing the system in a way that makes sense. So yeah, I do feel like collaboration is essential for us.
Collaboration is a must. I hope that needs to go on a shirt somewhere. Yes. Thinking about any other advice that you all have that you would offer to others seeking to strengthen their support for children's mental health. What kind of parting words or advice would you give to individuals who are interested in that?
I think I would say, like, as Dr. Vidal said earlier, if you want to support youth and families, you need to go where they are. So whether it's in the schools, in the communities, it is, not really reasonable to expect that they're going to come to you, that you can set up shop and they'll find you. I think being able to go into the community, and also, you come with expertise, which is really important, but you need to listen. You need to come in and create these family school community partnerships and be open to what that community thinks they need and how to best address it. So not coming in saying, this is how we're going to do it and why, but just, I have some ideas, let's work together to figure this out, and figuring out like, how do you do this so your mental health, your education, your health, whether it's juvenile justice or child welfare, like, how do we not end up working in silos? And we're all working with the same youth, so how do we make sure that we move away from silos and figure out how to best collaborate? So going back to Dr. Vidal's use of that word, collaboration is key.
Yeah, and I think I agree completely. I would add to that that sometimes we do have the best practices and best evidence-based programs, but people are still not coming to us for multiple reasons. So I think that going into the community makes a difference in that way. But I also think that my advice would be for fellows to try to expose themselves to every single type of care delivery, because maybe schools is not for everyone, but maybe it's for a lot more people than that are, that currently are doing it. In general, I think child psychiatrists have good intentions and they're doing pretty good in general. I would recommend to just people who have decision power over systems to create systems that are more, more about like smooth transition from service to service, that follow like a public health model where you have lots of services that are not high intensity for a lot of people, and then specialized services in other settings that are more costly. But I don't think the system that we have right now is great in some ways. And the ways that I see it is, for example, when I go to the inpatient unit and I'm attending there and I see a kid that has never received any treatment in the past, and the first thing they do is get into an inpatient unit where they get like one or two medications and no therapy or very little therapy during their inpatient admission, and then maybe they don't even follow up. So I think there's a lot of work to be done at the system level. And then I think that having a lot of it, I feel like child psychiatrists in general are very much thinking about the system just because of the nature of the child, depending so much on the environment. But I think that the fellowship could be an opportunity to see all of the different ways in which you can impact the system as a person.
Thank you both. I'm going to move to some of the questions that we have in the Q&A. You all were fantastic and answered a couple already. But just starting at the beginning, someone asked, how are you able to successfully involve caregivers into the treatment with school-based programs? Can you talk more about the barriers to developing a school-based mental health program?
I can start. In some ways, working in schools, it's harder to engage families because if you're in an outpatient setting, typically that parent partner comes to the appointment and they're driving that child or taking the bus with that child to get them to the appointment. So, we have to work a little bit harder in schools, and for some caregivers, schools may not have been their favorite place for themselves growing up. So we have to make sure, how do we create an environment that's safe for them, that they feel comfortable, and also kind of meeting the parent where they are. Many of our parents are working and very busy. They're dealing with childcare. They may not have the time during regular school hours to meet. So being flexible and creative, I think the pandemic taught us a lot that we hadn't even considered. Like, why did parents have to come and be in person with us for us to really communicate with them? Why couldn't we do a web call? Why couldn't we pick up the phone sometimes? And maybe they'll never be able to make it in because of their schedule. But I think through the pandemic, we became more flexible with how we were reaching out to families, and also thinking about who's the right person to really meet with you to help support the child. It may be mom and dad, it may be grandma, like who's staying with the child, who sees the most, and how do you expand that consideration so that we're meeting families where they are and treating them as they should be treated. Like, you're the expert in your child. Help us understand. Let's work collaboratively. Like, this should not be part of a blame game. If you want parents to be engaged, coming in and telling them everything their child did wrong is not going to help. This is where your child is successful. This is where we can help. What works for you at home? How can we bring that to the classroom? And kind of engage the family member as a team member.
Yeah, I would answer with that I feel like that school-based mental health programs have this bad reputation of not engaging the families as much because they don't have to be driven and the kid is at the school all the time. But in my experience, like I said earlier, because these families are under a lot of stress. They don't always make all the appointments for a long period of time. So the average I would get would be like 3 sessions, for maybe I had a patient who lasted for a year, but now I get to see them for over 4 years. And by the second year, the families, I can always call them on the phone if they're not able to make it. We can do a televisit if necessary. So I don't find that is a barrier as much now, because I still stay in contact with them. And for older kids, we don't always necessarily need the parent in the intake, although we do communicate with them by phone or by video. So I think there's ways to overcome that problem. I also think that I think it depends a lot on the population. Some kids have so many stressors that are stressors in the school, in the community, and maybe the parent-child relationship is not something that needs so much work. And then, but maybe in other families, then you do need to focus on the parent-child relationship more. So I think it also depends on the situation and the experience. But yeah, I can see that. I don't see, other than us having to move to the place, I don't see that as a barrier. Another problem used to be that in the summer schools closed, but now since the pandemic, it's become very common to just do a virtual visit over the summer. We used to go to the home before, now we do a lot more visits because of the virtual option. So
Thank you both. There is a connection to a question that we talked about earlier, but specifically, how can we best respond to risk to funding of school-based work and public mental health efforts? In particular, in regards to the risk for reversal of Medicaid.
I think Nancy, I have no idea.
Okay. One of the things we talk about school mental health is it's important to have braided funding, all different types of funding, not to rely solely on one source of funding. So I do think, figuring out like what are other resources, what is other sources for funding can be really important. And also advocacy, like reaching out to your local, to your state, to your national leadership, your legislators, and making sure that you're communicating the value of this. And this is something that should not be on the cutting board. I mean, I know therefore, as we're saying this, some cuts to Medicaid are being voted on today and have moved forward from the Senate. It's complicated, but I think that voice still does matter, and being open to figure out, creatively what other funding resources can there be so that the work can continue.
Right. Like for example, in our state, we're lucky that the state government was able to, even though they're struggling as well, but they're able to still fund some programs that provide services in schools. So I think if the state governments can do that, that's great. If local governments can do that, that's also great. I think at the individual level, I'm feeling a little discouraged about that, but there's probably things you can do even at the institutional level. But I do think that we have to be honest, these are like really challenging times for programs like this. So hopefully they can stay afloat as long as possible until the environment is better.
Yes. And in speaking further to the advocacy piece, by attending today and hearing about the importance of this work and being able, as Dr. Lever just spoke about, to leave the meeting, utilize the information in advocacy efforts locally and regionally and above. Yes, we feel discouraged, might feel discouraged now, but continuing to speak out about what's important for our patients and families can make real change. So there we have a few minutes left, and there's 3 questions that I think we can combine into one. So people are wondering, for child and adolescent psychiatrists who have quite a lot on their plate, and what are some practical things to do to support and collaborate with schools and education departments, as well as, just getting their foot in the door with working with schools. So kind of combine 3 questions into one.
I mean, I think I would just say really quick that I think there's many different models for school-based mental health. We're lucky in Baltimore that we have a really strong school-based mental health program. But when I hear from other child psychiatrists across the nation in the ACAP meeting, they talk about other models where maybe you get contracted by the school and or the district as a psychiatrist, or you connect with someone in the school to provide medication management while they provide therapy. So we have a model that's based on institutions and organizations that basically provide the same services that they would provide in the clinic. And they've been financially sustained, I think, because we bill to the insurance, in this case, Medicaid. But this could be done also with private insurances if the district gets, works it out with an institution or with a group of psychiatrists. So I think it's a question of like going out there and asking and trying to make it work, talking to the, districts and boards and mental health services in the schools. So.
And definitely agree with all that Dr. Vidal is saying. And I think, for someone who's super busy and may only have like one afternoon that they can give, like just going to a local school, obviously planning for this in advance, but even giving staff an opportunity to talk with a psychiatrist. What questions do they have? What do they want to learn more about? Like just doing an in-service can be pretty powerful. Sharing resources that you have about different mental health challenges and, providing some of those handouts to school staff can be pretty powerful. Being willing to serve on a committee, not one that meets too often, but just, I think having your perspective can be really helpful. And many of our schools and districts have no access to a psychiatrist. So I would think if you called up and, asked at the district or school level, how could I get involved? Here are some things that I'm thinking. What could I do? I think people would be pretty excited.
Well, thank you both for your time. I will let you know that there were a few shout outs in the general chat. Dr. Vidal, someone I think who has met you some years ago. And also a shout out from one of my colleagues, Dr. Melvin Otis, who is saying, continue everyone members to sign on to advocacy efforts as they relate to Medicaid. Speak with your legislators and your local ROCAP to keep fighting for services and tell the stories about the devastation that our patients and families face from these cuts. And so I thank everyone for joining. Your insights really help us better understand what we could do to build and sustain collaborative systems that truly support the mental health of children and families. Education is near and dear to my heart. I taught for 2 years before medical school, and all of the things that you're saying are like, yep. I felt all of those while I was teaching, and now being out of the classroom. Like I said before, collaboration is a must. Before we wrap up, are there anything else that you'd like to share? Any final thoughts, resources, calls to action for our audience? Anything you'd like, Dr. Vidal, Dr. Lever?
I mean, I would just say that I think child psychiatry is exciting because of this, because there's so many environments that you can work at and that we can impact so many things for kids to have better mental health. So I just suggest people explore, and I really think school-based mental health is the best way, but I'm biased. Sorry.
And I would say check out our National Center for School Mental Health, check out our website. We have a lot of free resources and tools that people can use. Please check those out. If you have questions, feel free to reach out to me or others on our team. I think school mental health is here to stay. If we want to reach youth, we need to continue to support school mental health.
Thank
Wait,
you.
you're muted.
Thank you. Oh, I almost got through the full session without talking while muted. Thank you again for your time and the important work that you do. Thank you to everyone who joined today. I hope that you continue to engage in our series, and we will put up a slide shortly. Here we are. That just shows our 2 upcoming sessions, one on July 15th that focuses in on juvenile justice, and one on July 29th with the focus being foster care. And so I hope that everyone will be able to join us. And the session is again recorded, and so you will have access. So thank you, everyone, and I hope you have an excellent rest of your day.